Dr. Upchurch. What a talk and opening. We have Dr. Chandler Long here from Duke. It's a distinct privilege and honor for me to introduce Chandler. Chandler did his general surgery training at Vanderbilt and UT Knoxville, and he trained in vascular surgery with Dr. Jordan and Emory. From there, he went to Duke, and there's probably not an award for educating students and younger trainees at any institution that Chandler's been that he has not won. He's an incredible educator. He is now director of the Vascular Fellowship at Duke and co-director of the Integrated Vascular Residency. He's also co-director of the Aortic Center at a young point in his career. And when we solicited Chandler about what he might like to talk about, he gave us a number of choices, and the choice that we thought was so provocative was trial by fire, what his experiences are as a junior faculty in the lead position. So Dr. Long, Chandler, welcome.
Thank you so much. It really is a pleasure to be back in Georgia, seeing a lot of old and new friends. Before I get started, I want to say that Chuck actually made me lie to my wife this weekend. She called and said, "How is the resort? How is it?" I said, "It's horrible, it's raining, it's just ugly," because I know that if I return home to 3 young kids on Sunday and there's these great pictures, I will end up like some of the patients I'm going to present to you today. So being mindful if anybody discusses this with my wife, but it truly is a pleasure, and thank you all so much. So I have no disclosures. So when I left Emory in 2016 and moved up to North Carolina, I knew that there would be some significant challenges as being young faculty starting in a new institution. You have to adapt into the culture, you have to integrate into the team, and it was advised that you find a supportive team and partners to collaborate with that would help you. I don't know if many of you are familiar with the Dunning-Kruger effect, but this is the way many people describe our surgical residents, and I'm sure that this was me, my first and second year in residency. And so as joining faculty, I realized that I really wanted to be on this portion of the curve to really have a smooth transition, and I think we all would like to do that. When I look at the learning curve with aortic surgery, it can be very steep and sometimes very brutal. When there are some recent papers talking about open surgery, which is being done less and less in our training programs, and it takes about estimated 30 to 40 as faculty to really get sufficient, not necessarily at the expert level, but get sufficient, and with the numbers dwindling, that may be even larger. When I look at some of the experts in the complex endovascular field with Oderich and Starnes, some of their papers show that it really is a curve over a 7 to 10 year period where they really start to take advantage of all this finished rated technology and do well. So I realized that if I'm going to be a true aortic surgeon, it's going to be a lifelong process. So I had to embrace creativity because I knew when I started at Duke there were many surgeons, as many in this room, that are much better and more experienced aortic surgeons than myself. And I saw this as an opportunity to get mentorship and learn. The downside is you're at the bottom of the totem pole in terms of getting cases. So I had to be creative and to say, well, how can I add value to this aortic team? And I saw that through pushing complex aortic solutions to some of our aortic patients with the goal of being a complete aortic surgeon many years down the road. So I'd like to share a few cases with you. This was a woman that was undergoing a spinal fusion procedure with neurosurgery, and unfortunately during the procedure they had a misadventure where either one of their drills or a chisel went a little bit more off to the side and punctured a vessel. They were able to pack it, abort the procedure, and they got the CT scan, and this is the scan that we were consulted with this 2.3 centimeter saccular or extravasation right at the level of the celiac. Now we had some options, but we had to realize that the SMA in both the celiac would be in play. We discussed doing an open approach, which would be significantly morbid, would delay her actual spine fusion, hybrid approach with debranching and then endovascular exclusion, but you probably have to cover more aorta than we would like. You could use parallel grafting, but gutter leaks could be very detrimental in the circumstance. So we elected to be creative and do a 2-vessel position modified aortic cuff. You see a picture of us modifying the graft there, and then our completion result. This patient was actually back in the OR in 3 days to have the completion of her fusion, and was out of the hospital in 7 days. And this was a 6-month scan in my clinic with no endo leak, and she wasn't the wiser, and really had an expedited recovery. This was a patient of Dick McCann and Chad Hughes, who they have been following for some time, that initially presented with an extent 3 thoraco. They monitored this patient, and then Dick McCann fixed her infrarenal aneurysm when it became of size in 2015, and then she was lost to follow-up. And unfortunately, Dr. McCann was not with us when she did come back, but was seen in Dr. Hughes' clinic, and he noted that she had a pretty rapid growth in a 6-month period in this visceral segment with a saccular aneurysm. So he said, hey, can you think of an endovascular way to deal with this, because she is morbidly obese, and I don't think an open option would be good. So the problem with the anatomy was that the patient had a very narrow true lumen and had this hourglass kind of anatomy that we had to account for. And so he came up with a creative solution by taking a double tapered thoracic vise, taking it off the delivery system, flipping it upside down, modifying that graft, and then combining that with a single tapered proximal device to really fit the anatomy and give her an elegant solution, which she did well. I wish I could say that that was the end of my talk, and those are all the good things that I like to show, but resiliency is a must, especially within aortic surgery. I tell the residents that you can learn from your wins and your losses, but I think the failure is a better teacher than when you win. There's a great quote by Ray Bradbury. We have to continually be jumping off cliffs and developing our wings on the way down, and I think for all junior faculty, that's probably something that you should just put inside of your jacket and take with you and refer back to. So I'd like to present some cases that didn't go so well. This is a patient that presented with mechanical fall to our trauma team, and incidentally was found to have a large extent 2 thoracoabdominal aneurysm. Complicating things is the patient had concomitant mesenteric ischemia and had a right-sided aorta. And so we had several issues to deal with and had to come up with a solution. Now, of course, this patient is not a traditional open candidate because of the right-sided aorta, so I initially elected to try to figure out an endovascular solution with target sending of the visceral vessels and then coming back with a branched endograft. Unfortunately, when I took him for the angiogram, I was unable to even select nor really find the celiac or the SMA. And so I aborted and decided to bring him back in a couple of days and talk to some of my colleagues about doing visceral debranching and EVAR-TEVAR. So Chad Hughes was willing to partner with me in this, and when we took the patient to the OR, unfortunately the patient had ruptured. So now we had an acute rupture, large retroperitoneal hematoma. We had to urgently rush the patient to a hybrid room, and then we did the endovascular exclusion first, then crashed into the abdomen to try to revascularize the viscera. We were able to do this all within about an hour, surprisingly, which shows having good collaboration. And then we decided not to revascularize the left kidney just because the hematoma was largely in that setting. This patient returned to the OR several times that day and the next day, but unfortunately succumbed. And this is a picture of the autopsy. It was very important to me that we participated in the autopsy because you want to make sure that no stone is left unturned. And if there's a place that we missed or messed up, we want to know that because we want to make sure we do better for the next patient. A buddy of mine who's not in medicine, we were drinking and I was telling him and lamenting about stuff, and he says, well, you can't let a patient die the same way twice or else you should be fired. And I think that's something that we should take to heart. This patient stuck with me for a while, and it was a patient that had a pretty interesting story. So this patient had a history of urothelial cancer, underwent excision, but then was treated with BCG. And now I'm not a urologist, nor am I an expert on adjuvant management of bladder cancer, but BCG was initially used for the vaccine for tuberculosis many, many years ago, and now it's found a space in the urologic field to treat bladder and transitional cell cancers. And this patient had EVAR in 2016 and then presented outside hospital with this mycotic aneurysm in the visceral segment, along with metastatic disease from the urothelial cancer to the spine. The patient was culture positive with mycobacterium, presumed from the BCG treatment. Now, I was not aware that there's been several case reports of this actually happening, and there's no real consensus on the best way to treat these patients, whether you can sterilize grafts if they're there. There's been success treating them both open and endovascularly. There is a 13 to 40% mortality rate when you look at these patients treated open. The endovascular patients tend to do better, at least in the short term, but when you look at the post-operative infectious complications, when you do treat them with stent grafting, there can be almost a 30% infection-related complication, and 20% of those patients ultimately pass away. So in collaboration with our ID team and many other people, we came up with a plan to just kind of keep it somewhat isolated. So my plan was to do, which we did, an internal bypass temporary bypass from the thoracic aorta to the iliac, as if this was a transplant patient, so we could perfuse the kidneys and then clamp above the stent graft and then above the aneurysm. And I resected this area and then did a bypass from the aorta to the celiac and SMA. Unfortunately, this patient had a long and very protracted course over a month and a bevy of complications that we can discuss over beer or bourbon later, but needless to say, the patient did not do well, and it was very hard for me to deal with that. I remember running into Ted Pappas in the hallway, and he came up to me and says, you know, you got to keep your head up and you got to keep your confidence, because tomorrow someone's going to ask you to do the same thing, and if you're sitting here whining and crying about it or feeling sorry for yourself, you're going to be no good to help that next patient. Some of you may know Dr. Pappas. He's a very, very excellent surgeon, and his timing was impeccable. It wasn't a few months, but it was within a year where I did have that opportunity again. And I think this quote by Winston Churchill, "Success consists of going from failure to failure without the loss of enthusiasm," is very important. So about a year later, another patient with urothelial cancer who underwent a right nephrectomy presented with now bacteremia and actually seeding of previous endograft after surveillance cystoscopy procedure. When I discussed with the patient the opportunities that we could offer him for surgery, he just declined and went home. IV antibiotics and followed up with oncology and infectious disease. They got several scans for their care, and they noted a new mycotic aneurysm that had been rapidly growing proximal to his stent graft, so he was referred back to me to now do something about this. This gentleman was not the healthiest, and we discussed the risks and benefits, and he decided to move forward with surgery. I wanted a completely autogenous repair, and we were somewhat vein limited, so we had to get deep vein from both legs and the basilic vein from the left arm, but we were able to fashion a thoracic aorta to left renal artery bypass, then bevel the visceral segment and take one of the deep femoral veins and come to the left common iliac artery. Again, we didn't have enough length, so we had to be creative, and then we used the other graft to come from an external artery bypass. This patient did remarkably well, was out of the hospital in 7 days, and despite my best advice, was golfing actually a month later, and though had other health issues, actually lived for several years after this and had great quality to his life. So in closing, I think that you got to be creative, you have to stay resilient, and always answer the bell and find people to collaborate with. I think that as young surgeons and all surgeons, the balance between humility and confidence is something that we have to walk a very fine line. So when I think about the Dunning-Kruger effect and losing confidence, you really want to be on that path where your knowledge and your skill level are kind of growing commensurately, and I think that this will be a lifelong journey for me, and thank you so much for the time.